Well, I'd like to welcome you all to this late afternoon session. We're all delighted to be here. My name is Dana Anderson. I work at the NIH. They tell us that there's only two responsibilities of the moderators. One is to start the session on time, and the other is to end the session on time. That's it. So we're going to accomplish at least 50% of our designated obligations here. And I'd like to begin by introducing my co-moderator, Dr. Melina Bellin, who is a professor of both pediatrics and surgery at the University of Minnesota, although she's not a pediatric surgeon.
I am not.
But we overlook that and accept her in spite of that. And she's going to introduce our first speaker.
Good afternoon, everyone. I'm pleased to have the honor of introducing our first speaker. And I will say for this session, we are going to take questions at the end of each talk since there are different abstracts being presented here. But we will welcome up Anna Evans-Phillips. She will be presenting on exocrine pancreatic insufficiency incidence at 12 months after acute pancreatitis, a prospective multi-center study.
Thank you and good afternoon. Thank you so much to the moderators for the kind introduction and also to the organizers for giving us the opportunity to present our work this afternoon.
Start the clock.
And so I have no financial disclosures to start out with, but I'll start rather with a bit of background. And so exocrine pancreatic insufficiency, or EPI, occurs following acute pancreatitis, but at variably reported rates in the literature. Up to 62% of patients have been described as having EPI during their index admission for pancreatitis, and up to 35% have EPI in follow-up of differing duration. Contributors to this phenomenon have been thought to include damage to pancreatic acinar cells, including inflammation and necrosis, as well as impairment in pancreatic enzyme secretion. The majority of patients with acute pancreatitis experience rapid resolution of their abdominal pain. However, the timeline to recovery of exocrine function still remains unclear. This systematic review and meta-analysis from 2019 shows us a very interesting picture. What we see here is the time course of the pooled prevalence of exocrine pancreatic insufficiency during and for approximately 5 years after an attack of acute pancreatitis. Now, this work is very important, but it has three important limitations. And those limitations include that much of this data was collected retrospectively. The rates of exocrine pancreatic insufficiency vary significantly between the studies that are included here. And also, the ways in which EPI were defined between these studies were also quite different. So the aim of our study, the post-acute pancreatitis pancreatic exocrine insufficiency, or PAPA study, were to establish both the burden and predictors of EPI at 12 months after acute pancreatitis in a large prospective multi-center cohort. This is a multi-center study performed at 3 tertiary care centers, Ohio State, the University of Pittsburgh, and Johns Hopkins University. And adult participants of 18 years at a minimum were enrolled with acute pancreatitis at the time of their attempt to resume nutritional intake, either oral or enteral, after their inpatient admission with attack of acute pancreatitis. Now, exclusion criteria for this study included pre-existing chronic pancreatitis, pre-existing exocrine pancreatic insufficiency, malabsorptive disease, pancreatic surgery, or pancreatic cancer. Stool samples were collected from these patients at baseline, 3 months, and 12 months. And fecal elastase, or FE1 levels, were measured from those stool samples. Exocrine pancreatic insufficiency in this study was defined as a fecal elastase level of less than 200 micrograms per gram of stool. Now, the severity of exocrine pancreatic insufficiency, as we defined it looking at several different subgroups, was that in patients who had an FE1 of less than or equal to 100, they were determined to have severe EPI, and those with FE1s of 100 to 200 were determined to have mild EPI. Those with an FE1 level of greater than 200 were thought to have normal. Now, both a univariable analysis and then a multivariable analysis were performed, with the latter being controlled for acute pancreatitis etiology, pre-existing diabetes, and acute pancreatitis severity. In all of the participants who provided a 12-month stool sample, of whom there were 85 in total, exocrine pancreatic insufficiency at 12 months was diagnosed in 29, or just over 1/3, 34% seen here. This diagnosis at 12 months was associated with etiology of acute pancreatitis, history of recurrent acute pancreatitis, pre-existing diabetes, baseline exocrine pancreatic insufficiency, and the severity of acute pancreatitis. Now, we looked at several different subgroups of interest, including those for whom this was an index attack of acute pancreatitis, those who had had mild acute pancreatitis as opposed to moderately severe or severe disease, and even those who had an index attack of mild acute pancreatitis. And the interesting point here is down in the lower right-hand corner, which is that of those patients who had mild acute pancreatitis for whom this was their index attack, still there was a prevalence of 12.8% of EPI at 12 months after their attack. And so the point here is that it is unlikely that these patients could have had persistent inflammation, necrosis, or acinar cell destruction that would be the sole driver of their EPI at 12 months after attack. And so this suggests to us that there are likely to be other factors at play in this population. The multivariable logistic regression for EPI at 12 months was notable for several independent predictors, including idiopathic etiology of acute pancreatitis, severe or moderately severe disease, and pre-existing diabetes. This figure shows us the prevalence of mild and severe exocrine pancreatic insufficiency at baseline on the left, 3 months in the middle, and 12 months on the right after acute pancreatitis. Severe EPI is noted in the red portion of each bar, and mild is noted in the blue portion of each bar. And what you see is that there is a trend toward recovery from EPI from baseline towards 12 months. The recovery seems to occur, in this population at least, in those who have severe EPI more than those who had mild disease. This Sankey diagram shows us roughly what the natural history of EPI by fecal elastase measurement is over the course of 1 year after acute pancreatitis in our specific cohort. Now, this diagram shows us all 112 patients on the left-hand side who provided stool samples at their baseline enrollment. And what we see overall is that the majority of patients who did not start out having EPI finished the study also without EPI. However, there are definitely some patients who cross over and develop new EPI in the course of those 12 months. Similarly, in the 48 patients who exhibited baseline exocrine pancreatic insufficiency, the majority of those patients finish out the study still with exocrine pancreatic insufficiency. But again, we do see some recovery in those patients over the course of those 12 months. Now, acinar cell destruction and inflammation may impair the release of enzymes. However, additional pathophysiologic processes may be at play, as I mentioned. EPI at 12 months is definitely seen after mild acute pancreatitis without necrosis. As I mentioned, in those patients for whom it was their index attack and they had mild acute pancreatitis, the prevalence is still 12.8%. Several patients also developed new exocrine pancreatic insufficiency in the 12 months after acute pancreatitis, again, making persistent inflammation or destruction of their acinar cells unlikely as the main driver. In this study, idiopathic acute pancreatitis was independently associated with EPI at 12 months, and this suggests again that there are likely to be, as of yet, unidentified risk factors. We still have a lot of work to do in this field. Diabetes mellitus at baseline was independently associated with EPI at 12 months as well. And so here, we might at least consider that there could be immune factors at play contributing to development of EPI, or that there is underlying compromise to the pancreas that at this time still remains poorly understood. Limitations of this study, which we can certainly acknowledge. First, the use of fecal elastase to diagnose exocrine pancreatic insufficiency. We can all acknowledge that this test certainly has limitations. However, it represents the state of the field at the current time, and this is the best test we have available to diagnose exocrine pancreatic insufficiency in the clinical setting. All participating centers in this study were tertiary care centers, and so this may be a source of mild bias for this study. Additionally, the dropout rate was 24% between those who provided stool samples at baseline and those who provided them at 12 months, another potential source of bias given that there may have been some degree of participation motivation for those patients who suffered from symptoms to continue at 12 months. And so in conclusion, I would like to highlight that exocrine pancreatic insufficiency is present in more than 1/3 of this prospectively assessed patient population at 12 months post-acute pancreatitis. The independent predictors that we identified for the presence of EPI at 12 months after acute pancreatitis include idiopathic etiology, moderately severe or severe acute pancreatitis, and diabetes mellitus at baseline. Longer-term data and investigation of the pathophysiology are, of course, needed to further understand the persistence of EPI following acute pancreatitis and its contributing mechanisms. And so with that, I would like to say thank you to my co-investigator and longtime mentor, George Papachristou, as well as Drs. Phil Hart and Stacy Culp, who have been very instrumental in helping us understand and interpret the findings of this study. And to all the rest of the co-investigators, thank you. I'm happy to take questions.
We'll invite questions to the microphone, please.
That was great. I was wondering, in follow-up, did you find that the patients that had low elastase had additional clinical features of symptomatic insufficiency, like they couldn't gain weight or they lost weight or they had steatohepatitis or some other clinical features?
That's a great question. And what I would say is that that data is coming soon. Unofficially, I would say, it's been very difficult clinically to correlate specific symptoms with the findings of our fecal elastase levels. And so I think we have some work to do in larger populations to understand better what is a reliable symptomatology. But like I said, we hope to be sharing that data soon.
I was wondering about the mechanism in the patients with diabetes. Does diabetes impair recovery of acinar cells after pancreatitis? Do we know that? Was there a mechanism?
That's an excellent question, and I have to confess that there are probably people in this room who are better posed to answer that than I am. I don't know the answer off the top of my head to that, but it certainly bears asking, with the findings that we see here, and I think additional, studies are needed both in preclinical and clinical settings to understand how that works in concert with one another.
Hi, Megan Golden from Mission Cure. I may have misunderstood this, but I thought that the baseline rates of EPI were also pretty high. And if that's true, to what do you attribute that?
Oh, that's an excellent question. And so again, I would say that we are still in need of additional research to understand what the pathophysiologic processes are during that time. Initially, I think there's a consideration that there may be a kind of stunning of the pancreas in the setting of acute inflammation, just that these patients are not having, as much enzyme output in the setting of acute inflammation, regardless of the severity of the disease. I think in addition to that, what I would say about this patient population, that baseline stool sample was collected within 30 days of their hospital admission, but it had to be after they started either oral or enteral nutrition. And so in this patient population, I can say that it is not because they are not eating, but rather that we are seeing some effect of a lack of production from the pancreas.
Anna, maybe I'll take the liberty of asking you one follow-up question on the
Please, yes.
diabetes. And you may have seen this, and maybe I said this and missed it, but the treatment of the patients with pre-existing diabetes, was there a relationship between insulin treatment and the exocrine insufficiency, or did you look at that?
That's a great question. We have not yet looked at that, but I think we really should in order to understand better how those phenomena are related. Thank you.
All right.
Great. Thank you
That's
so
all
much.
the questions. Thank you very much for that beautiful talk. Turn it over to you.
So our next speaker is Dr. Yves Dudal from Persigo Pharma. who's going to present novel gut-restricted nanomedicine represents major breakthrough in exocrine pancreatitis insufficiency.
Thank you very much. It is with great enthusiasm that I'm here today in front of you to present the novel nanomedicines that we at Perseo Pharma have been developing in close collaboration with our colleagues at Nestlé Health Science to address a breakthrough in exocrine pancreatic insufficiency treatment. And I'm very pleased to be joined today by John Watson from Nestlé Health Science here in the audience as well. Oh, okay. Sorry. There we go. The standard of care for oral pancreatic enzyme replacement therapy do exhibit relatively poor drug profiles. Indeed, the enzymes provided in their free form are quickly deactivated in the GI tract and highly susceptible to harsh conditions. This leads to strong overdosing and the pill burden for the patients who have to take those, having to take up to 10 pills per day, in some cases even more. Associated with that, there are cases of gut inflammation and drug intolerance, safety concerns, due to the fact that in the PERTs, for example, 1% is lipase and 85% are proteases, and we'll come back to that and their potential impact. So overall, we have some relatively unsatisfied patients and doctors, and room to improve that. And this is what we have been doing at Perseo, using our unique and proprietary platform technology to shield enzymes. And basically, we can apply this platform to any therapeutic enzyme, and we shield it, we embed it into a silica-based, organosilica-based shield, soft shell, if you want, and further decorate these with a mucus-binding moiety, which is the natural molecule chitosan. The end product is a nanomedicine that goes and binds to the mucus of the small intestine while completely protecting the enzymes from deactivation. So not only do we increase the time during which the enzyme is active because it remains active in its soft shell, but on top of this, we also increase the residence time of the whole construct in the small intestine by mucus binding. It is important to note that these enzymes are not released from their soft shells. They're active in the soft shells. It is the substrate which migrates to the active site through the shell, which is porous, to reach the active site and react. I've put a little picture of a statue in Florence at the bottom left of this slide, and this is Perseus, and our name comes from that. Perseus was able to go and slay the deadly Gorgon Medusa. Medusa would look at you and turn you into stone, and he was able to get close to her because he was wearing the beautiful cap of invisibility that you can see here. And we foresee our enzymes to be invisibly able to slay the disease as well. Now, the platform, we've of course checked the drug profile of the platform-derived drugs that we have, and it shows quite remarkable drug profiles so far. First of all, we've checked the biodistribution, and do we actually bind to the mucus? Do we do something to increase the residence time? Yes, we do. We've done that into mini pigs, but also in mice studies, where we've shown with radio-labeling tracer using radio-labeled particles that we have a threefold increase in the residence times due to this chitosan decoration of the nanomedicine. We also show that efficacy is there because once embedded in the soft shell, the enzymes can no longer unfold themselves and lose their activity. So we have very stable activity over time. And in terms of safety, it is important to note that those nanomedicines remain non-systemic. They are strictly gut-restricted. We have not found any trace of radioactivity in any organ or in the circulating blood. A couple of years ago, this initial slide deck came on the desk on the deck of John here. And he called us and he said, we need to try to work together. We need to try to do something with the pancreatin or the pancrelipase. And so we decided to get at it. And we designed what we call now PER-301, which is the drug candidate at the preclinical stage at Perseo, which is basically the embedment of lipase, proteases, amylase, all the enzymes that are contained in the pancreatin coming from the porcine origin. Our ideas and our objectives were and still are to provide expected patient benefits in terms of lower dosing, possibly, decreasing the pill burden, and improving the safety. So let's see if we manage that. The first thing we did after, of course, designing PER-301 as such was to work with the animal model, which is a mini pig to which the pancreatic duct has been ligated, so no longer able to excrete any pancreatic juices. We dosed this PDL mini pig with PER-301, and we gave it some triglyceride or olive oil, and we quantified the plasmatic triglycerides derived from the digestion of the olive oil into the blood. And as you can see, the profiles of the healthy mini pig and the mini pig treated with PER-301 are very close. And this, remarkably, despite the fact that we've only given 1,300 units to digest all the olive oil that were given to the mini pig, which is quite remarkable because basically when you treat someone with enzymes, you're able to calculate the dose you need, right? A unit of enzyme is a micromole of substrate degraded per minute. So you're able to calculate how much you actually dose and what the efficacy of that can be. And here you can see that we were able to have a good profile, very similar to the healthy mini pig, 62% in area under the curve. And so we were able to validate the dosing calculation and move forward. The next step was to have a therapeutic study in vivo, still with comparing healthy mini pigs and PDL mini pigs. And basically, we acclimated the mini pigs to a high-fat diet, and then dosed the mini pigs either once per day or twice per day at each meal. And we benchmarked this to the pancreatin at the standard of care dosing, which is 80,000 units per day. And here we were either 1,300 or 2,600 per day. And we, of course, monitored the feces for the fecal fat content. Looking at the results, we see that despite the much lower dosage that we brought to the mini pig, we were able to actually increase the digestion efficacy by 25% with a 30-fold lower dose. 30-fold lower dose. Of course, this is due to both the increased residence time in the small intestine at the site of action, but also due to the fact that the enzymes remain active throughout the 8 hours of this residence time in the small intestine, which is quite remarkable. There's no loss of activity there. It also means when we look at this altogether is we did some calculation and we show that 1 unit of the pancrelipase can digest 0.14 milligram of fat, while the exact same enzyme embedded in the soft shell ends up being able to digest 6.3 milligram of fat. So what our platform does is that it increases dramatically the potency of that enzyme. It's the same enzyme, it does the same job, but its potency is orders of magnitude higher. We also look at the potential impact in terms of safety. We know that when we dose pancreatin at a high rate, there's a lot of proteases that do come along in the mixture. As I said earlier, there's roughly 1% lipase in pancreatin and 85% proteases. This is something that we've seen this morning in a talk from Dr. Di Magno. And it's quite interesting to see that when you overdose with proteases, you can actually damage the immunity of the GI tract, but you can also damage the barrier integrity, which is, of course, something you want to avoid and not to have at all. What we've done here is that we have built a intestinal epithelium cellular model in-house at Perseo in our labs. On the left, you can see that with two kinds of cells able to produce the mucus and reproduce a nice GI environment, small intestine environment. And we've applied a technique that's called the TEER, the transepithelial electrical resistance. It gives a very good idea of the integrity of the barrier, and if this integrity is maintained, then the TEER, there's a strong resistance to the passage of current, and so it stays very high, close to 100, and when the barrier integrity is lost, then the curves go down and we lose it. And you can see here that indeed, with increasing dosage of proteases in the system, we lose the barrier integrity. And this is mostly due to the fact that the tight junctions between the epithelial cells, and we see that on the right here, the lines in between the cells, the green lines, those are tight junctions with the specific biomarkers. We see that we lose these tight junctions and we lose the barrier integrity with high levels of proteases. Now, with our product, with the PER-301, the proteases are also embedded in the soft shell, and basically they don't have access to the cells and to the tight junctions. They cannot degrade them. And secondly, they are at a much, much lower dose than, of course, the proteases free. So overall, as a take-home message, we have I would say, a major preclinical breakthrough in the treatment of EPI. By shielding digestive enzymes and increasing their active residence time at the site of action. It led to a 25% more fat digestion, a 30-fold lower dose, and indeed a 45-fold improved potency. Now, the next step that we are undertaking with Nestlé Health is to replicate this set of data, but this time with the drug product. So really the capsule and the powder of those nanomedicine inserted into enteric capsules for delivery into the mini pigs at the duodenum. Overall, I would like to extend my warm thanks to all the contributors of this study, both on the Perseo side and on the Nestlé Health Science side. But I would like to also address a quick and warm thanks to the investors of Perseo Pharma. Perseo Pharma is a startup company in Switzerland, and a very special thanks to Mission Cure Capital, and Linda and Megan are here today with us, and it's really nice to have their support along the way. Thank you.
So this interesting description of drug development is open for questions. Dr. Uch.
Very interesting presentation. So it's very exciting that there will be some options to reduce the amount of medications that the patients take. My question is, so I'm thinking about patients with cystic fibrosis who take pancreatic enzymes and they have very thick mucus. So what would be your anticipation that this thing that is adhered to the mucus will perform in a patient with cystic fibrosis?
I don't have the answer to that question yet. What is clear is that we have been working with ex vivo mucus. We collected mucus from a pig intestine, and we've been working all along. There is good binding to mucus. It's pretty strong, and actually the whole PK of that drug candidate is or follows directly the mucus turnover. So it is true that my anticipation to your question would then be to probably even more increase the residence time in the small intestine, because I suspect that the mucus turnover in your patients is actually much slower than in healthy people.
Right, I think it probably is going to require a whole new area of research. It's a very thick adherent mucus, and the flow is very slow.
Very
so
slow.
It's probably going to be a whole area of research.
Yes, thank you.
I also have a question, also about a specific patient population, but I see patients who have had pancreatectomy and pancreatic surgery. So does this target to a specific area of the small intestine, or more specifically, if someone has a duodenectomy, do you think it's still effective?
We're not specific to any specific area. We bind to the mucus, and we actually we aim at delivering the nanomedicine at the duodenum level or early small intestine with an enteric capsule. If we were to give the powder directly in the mouth, it would bind to the mucus of the mouth.
Let me ask a question. What is the process by which this encapsulated combination of enzymes is actually degraded and disappears? It looks like it has a very long half-life of duration, but what accounts for its disappearance, for its metabolism?
It's a good question because it's not metabolized actually. It's excreted in the feces. We recovered 100% of the radiolabeled particles, nanomedicines, directly in the feces of the animals.
Terrific. Any other questions? If not, thank you very much for a nice presentation.
All right, so up next is Dr. Sandeep Swain, and his talk is entitled The Mechano-Gated Ion Channel Piezo-1 Regulates Pancreatic Exocrine Secretion via Dynamic Changes in Cell Volume.
Thank you, moderator. Good afternoon. As you know, pancreas is highly sensitive to pressure. So even if slightly touching the pancreas or manipulating pancreas can cause pancreatitis. In pancreas, if you see, these are the isolated pancreatic acinar cells, which accounts for 95% of the whole total pancreatic tissue, and the necrosis of these acinar cells, the major event in the pancreatitis. And you don't know, before it was unknown how the pancreas sends pressure, we discovered that the pancreas express mechanical gated ion channel piezo-1, which is highly expressed compared to other mechanical ion channel. And when you check the immunostaining image of the pancreas tissue, as you see here, that is the acinar cells which express amylase, red in color, and the high level of piezo-1 expression in the pancreatic acinar cell. And if you notice that the piezo-1 expression is more in the basal surface of the acinar cell compared to apical surface. So what is piezo-1? The piezo-1 is a mechanogated ion channel. It's a big protein and 2,500 amino acid and it 32 helices transmembrane helices. So making this channel is the largest transmembrane domain channel. So this channel is a homotrimer, means the three subunits make the channel functional. And you see the three blade-like structure of the channel which can sense the mechanical force. And the center of the channel is ion formation path. So it carries the ions inside the cell. And it mostly carry the calcium ion from outside to inside cells. We can activate these channels by applying mechanical force through static pressure or through shear force or through stretching the membrane or deformation of a membrane. Or the channel can be activated by chemical agonist IODA-1. So if we discovered that if the piezo-1 expressed in pancreatic acinar cell membrane, so if you apply the mechanical force, we can end up with intercellular calcium elevations. To prove that, we use a glass pipette. As you see the glass pipette around the 2 to 3 micrometer tip. So when I applied the mechanical force to the acini with glass pipette, if you see it increase intercellular calcium and the slightly touching of the acinar cells, we cause a transient intercellular calcium rise. So to prove that this calcium rise is piezo-1 dependent and a mechanical force, the piezo-1 is the key mechanical ion channel in the pancreatic acinar cell. So we made a transgenic mice where we knock out piezo-1 in the specific to acinar cell, and when we applied the mechanical force to that piezo-1 knockout acini, as you see here, even slightly touching of the pancreatic acinar cell, we didn't get any intercellular calcium rise. So the question is here, what are the physiological function of piezo-1 in the pancreas? If piezo-1 is highly expressed in the pancreatic acinar cells, there should be a physiological role. As you know that a pancreatic acinar cell is known for its exocrine function, like it stimulate digestive enzyme, and the classical secretagogue like cholesterol 8 at picomolar range can cause intercellular calcium oscillations, and this intercellular calcium oscillation is associated with secretions. So the question is here, so in our lab we always do amylase secretion assay from isolated pancreatic acinar cells. Most of the time we do the assay in the lab table because we don't keep the cells for a longer time. In couple of hours we isolate the cells and finish our experiment. When we do the assay in the cell culture hood, we came to know that a high basal amylase level in the control group without adding any secretagogue compared to the lab table. So Dr. Liddell and me, my mentor, thought that maybe something wrong in the cell culture hood that causing more basal amylase release. So when you notice that the cell culture will have strong vibrations, that vibration may be triggering the amylase release. So we suspect that maybe that mechanical vibration is activating PGO1 channel in the pancreatic acinar cells, stimulating the secretion. To prove that, we use a PGO1 agonist ODA1. Generally here we use a very low dose of ODA1 like 2 micromolar, which is quite non-toxic to acinar cells. When you applied ODA1 to isolated pancreatic acinar cells, as you see here, there is the intercellular calcium oscillations. It is not exactly like the CCK mediated calcium oscillations, but we find a pattern that the increasing and decreasing calcium oscillations is there. Then we go for the confocal microscopy to exactly study the secretion. As you see here, this is the F-actin coated phylodene. So generally in control group we didn't see any secretions, and when the zymogen granule secrete, the zymogen granule is coated with F-actin. As you see here, this is the zymogen granule coated with F-actin and fused to the apical site of the duct side. So as you clear here, the 2 micromolar ODA1 is sufficient to trigger the zymogen granule fusion to the apical site. To confirm it again, we use a flexible lysine rhodamine dye. The dye stay inside the duct. So when the zymogen granule fused to the duct, the dye can go inside the granules. So you can see that the dye in 2 micron ODA1 cases, the dye is going inside the zymogen granule, suggesting that PGO1 at the physiological level is sufficient to trigger the amylase secretion. So then we study the dose response of ODA1, and we observe that 1 or 2 micromolar of ODA1 is cause the maximum amylase secretion from pancreatic acinar cells. This is one of the old study, 1989, from Science paper. They study on the salivary glandular acinar cells. They observed that when there is a secretagogue cause intercellular calcium rise, initially they cause rapid increasing intercellular calcium rise, which is associated with the cell volume change. And during process, the cell volume change subsequent change, the cell volume change undergo also several times during the secretion, which is tightly coupled to the intercellular calcium oscillation. So we hypothesize that if PGO1 can cause intercellular calcium oscillation, we hypothesize that maybe physiological activation of PGO1 may lead to dynamic changes in cell volume and regulate secretion. To prove that, we use different methods to study the acinar cell volume change. We found the calcium AM dye method is more appropriate because the acinar cell is a multi-cell structure and it is uneven height of the acinar cells. So this is an indirect method to measure the cell volume change. We load the cells with calcium AM. The cell fluorescence intensity will be remain intact unless there is any change in the cell volume. To study this assay, we use different osmolarity solution to standardize our assay. So here, if you see here, if you apply the hypertonic solution to mouse pancreatic acinar cells, that cause a increased cell volume of those acini. Then using this method, when you applied the ODA1 at 1 micromolar dose, cause a transient increasing cell volume. It is stay like 10 to 20 second, and then cell shrink and subsequent contraction. So we believe that initial swelling of the cell volume because of the influx of calcium, then this contraction of acinar cells may lead to the secretion. To prove that, okay, if PGO1 regulates secretion, the major cause of secretion because of secretagogue induced secretions. So we thought that maybe PGO1 regulate during the pancreatic secretion, which is stimulated by secretagogue cholecystokinin. So when you apply cholecystokinin 10 picomoles, it causes intercellular calcium oscillation like a classical physiological secretion. In the pigeon knockout mice, that sustained intercellular calcium elevation is blocked. These are 3 acinar cells from 3 different acini, and most of the cases we found there is the decrease, the impaired in the sustained intercellular calcium oscillations. This suggests that maybe PGO1 in the somehow regulating that sustained phase of the intercellular calcium oscillation and regulating secretion. So when you do the dose response curve with the ODA1, with the wild type mouse and PGO1 KO mice with the CCK, you see that the PGO1 KO acinar cells, the amylase secretion is drastically decreased. And when you go applied with the CCK and ODA1 only 500 nanomolar, the sensitivity of pancreatic acinar cells, wild type pancreatic acinar cells, increase almost like 30 times more than the wild type acinar cells. So this is quite interesting that little amount of ODA1 like 500 nanomolar, very quite low concentration of ODA1, that increase the sensitivity of pancreatic acinar cell. So as you know that 10% of people over 80 years have a pancreatic insufficiency. There are different multi-factor can associated with this, like a loss of pancreatic parenchyma, fibrosis, or atrophy, or could be the loss of hormonal point of view. But we hypothesize that maybe PGO1 in the old people may have associated with pancreatic insufficiency. To study that, we use a fecal fat assay. So we have taken 2 groups of mice. One is old mice group and is young mice group. The old group mice we as 18 months to 24 months old, and the young group we kept at 3 to 6 month old. If you see here, the old mouse, the fecal fat content was really high, almost like 2 times compared to young mice. And when you check the PGO1 expression in that both group, the level of PGO1 expression is significantly decreases in the old group. Then we thought that, okay, if the PGO1 is regulate the pancreatic secretion and affect the pancreatic secretion in the old mouse acini, so we studied the dose response of a young mouse and old mouse pancreatic acinar cell with a CCK. As you see here, the old mouse, the pancreatic acinar cell is quite less sensitive to CCK compared to the young mouse. In the same condition, when we applied ODA1, here I have used like 200 nanomolar of ODA1, very low dose of ODA1. That reversed the sensitivity, and it didn't reach that level like young mice, but it reversed like it has a normal sensitivity and biphasic curve like a normal acinar secretions. So from this study, we summarize that physiological activation of PGO1 stimulate enzyme secretion, and secretagogue stimulation induced transient cell volume can activate PGO1 channel, and that regulate intercellular calcium oscillations of acinar cells and regulate secretion. We have to do more because we have to find the signaling pathway, the contribution of extracellular and intercellular calcium in PGO1 mediated acinar cell secretion. But we believe that PGO1 may be important in pancreatic insufficiency of aging. As our first speaker described that some few percentage of people have a pancreatic efficiency after acute pancreatic injury. We don't know, maybe that population of patient may have PGO1 deficiency. That could be another study. Thank you.
Thank you. We'll take questions on that presentation.
I can ask a question. So it's interesting. Is there like a piezo-1 inhibitor or antibody? So can you make somebody like perhaps exocrine pancreatic insufficient by giving a piezo-1 antibody? And the other thing I was thinking, like, if this is a mechanoreceptor and then, perhaps a clinical correlation, somebody has, obstruction, and then, can you perhaps just look into the mechanism by giving a piezo-1 inhibitor and reducing the secretion that way? I guess my question is that.
Yeah, I think it's excellent question. Unfortunately, we can't. There is one inhibitor like GSM test 4, which can block other ion channels also, like TRPC or sodium channel 1.7. But the channels express everywhere in the body. So it has, if you block this channel completely, I don't know how the people behave, because the global knockout of this channel is lethal. So when they knock out completely PGO1, they lead to the developmental impairment of the blood vessel, like a lymphatic system, and the blood vessel development is impaired. So we can use like transient vibration things, like making something like that. We can after taking meal, you can activate pancreas by using some vibration things, so that we can increase more secretions. Could be possible, but I think the blocker of PGO1, it will be really challenging. It's difficult. Yeah.
All right.
Yeah.
Any other questions? Yes, Dr. Hussain.
Thank you very much.
Thank you.
Suhail Hussain from Stanford. We could make this an offline discussion.
Yes. Yeah.
But since you're asking for questions, I thought, first I want to congratulate you, because
Thank you.
I mean, some of the things that you think about for years, we've been always shaking, asking ourselves, that's how we were taught. It's in protocols, and now we're going to check to see whether shaking makes a difference, because this is an important question about, what mediates secretion. The other interesting part about this is something I asked you maybe a week or two ago, which is that it's all connected. Calcium-mediated proteins, downstream effectors for physiology and disease.
Yes.
But we're looking at the downstream effectors, such as calcineurin, calcium phosphatases, and through various phosphoproteomic screens, we've actually identified substrates of these calcium-mediated proteins, phosphatases, that are actually attached to centrioles and primary cilia. And so you wonder whether there's microdomains of calcium. And the swelling is an interesting story, and that may be a factor. But I wonder whether there are microdomains. Every epithelial cell has some primary cilia, and whether piezo1 is responsible for some physiological functions that are in these microdomains.
I think it could be, because all the ciliary movement needs some mechanism sensor. And I think the PGO1 downstream signaling in the physiology, we don't know in the acinar cells, like it may be different pathway, like phospholipase C mediated, or calcium calmodulin mediated, or cyclic AMP mediated. So I think it is a big good studies there, so we can investigate that, like what are the ciliary movement in the controlling the cell volume changes, which is dependent on the PGO1 downstream signaling pathway. I think we can think for that, and maybe next year we can be able to answer the things. Yeah.
So I'd like to ask a question. Looking at the diagram that you're looking at the screen right now, it reminds me that exocytosis is a process where endocytic vesicles fuse with the plasma membrane of the cell and release their contents into the extracellular domain. And when they do that, the membrane, if you will, of the exosome becomes part of the plasma membrane of the cell. And one of the interesting facts of physiology is that the cells are able to recycle this bilipid membrane, so that the cells over time remain essentially the same size. They may expand a little bit, they may contract a little bit, but this process of exocytosis, which is so exuberant in pancreatic acini, means that there's this constant process of exosomes fusing with the plasma membrane, releasing their contents, which leads to the question, where is piezo1? Where does it reside? Is it on the exosome? Is it on the plasma membrane? And is it involved with the fusing of the exosome to the plasma membrane to affect secretion?
It is expressed in the plasma membrane, and we don't know if it is expressed in that exosomes or extracellular vesicles or not. I think I don't know how the mechanism, which rho kinase or some kinase pathway may be regulated to the exocytosis process controlling, but we have no. I don't know the PGO1 expression inside the cell.
Any other questions? Great presentation. Thank you so much.
Thank you.
Our next presentation is by Dr. Mezam Abu El-Haja from Cincinnati Children's Medical Center. She's going to present the role of pancreatitis risk genes in diabetes development post-index admission for acute pancreatitis. Dr. Abu El-Haja.
Thank you, Dana, Melina, my dear audience. If I can start. Yes. Thanks for the organizers for allowing me the chance to present our work to you today. On behalf of the whole team that participated in this work entirely through a journey that took 7 years to get to this stage. So these are the relevant disclosures to the talk. So what we know from some of the adult studies that newly diagnosed diabetes mellitus after a single episode of acute pancreatitis is a phenomena that we deal with in about 30% of the cases that happens at the 12-month follow-up. But if you wait longer for 60 months or more, it could be up to 60%. We also know that from the same puppy cohort that Anna spoke about earlier, in a multi-center study in adult patients of acute pancreatitis, if we look at the incidence of new onset diabetes at 3 months and 12 months, it's 4 and 10% respectively. But if you combine diabetes with pre-diabetes as a hyperglycemia, it is up to 18% at the 12-month follow-up. We looked at this in children from a cross-sectional analysis standpoint, and this included all comers with pancreatitis, and we wanted to look at the prevalence of glucose abnormalities after pancreatitis. And from the ones that had glucose abnormalities, which is pre-DM and DM together, we had about 25% of the ones that are actually tested. 15% happened after a single episode, 47% happened after the second episode, and the rest were after chronic pancreatitis diagnosis. In the same study, we found that older age and a BMI of the overweight or obese range, as defined by the CDC, and having a severe acute pancreatitis prior to the testing were all associated with an increased risk for prediabetes and diabetes. More on the background, we know from INSPIRE, as the largest acute recurrent chronic pancreatitis in children, that diabetes happens in that cohort at about 6%. But dedicated studies for a single acute pancreatitis-related diabetes are really needed in children, given that children have different etiologies and clinical presentations compared to the adult cohort. Our adult colleagues have an active consortium, it's T1D-APC, that prospectively followed adults for the risk of diabetes, and children are not examined through that consortium. So dedicating studies to them through these efforts are very important. More on the significance, diabetes is an under-recognized phenomenon, and if you don't screen for it, you're not going to find it. While it's known that pancreatitis risk genes do carry a risk for pancreatitis, it is not fully known how these exocrine-related risk genes could affect the endocrine function or the endocrine compartment. So to bridge this knowledge gap, we designed an observational study following children from their index AP admission and built a model for DM development over time. The hypothesis was that children are at risk for diabetes after their index AP, and that variants in the pancreatitis risk genes would play a role in diabetes development post-acute pancreatitis. The aims of the study, the main objective was to determine the pancreatitis risk genes and their variants and how they could be associated of a prediction for pre-DM and DM. It also wanted to examine patient and clinical related factors and how they could be incorporated with the genetic models to identify patients at risk for diabetes. This is our cohort design. At Cincinnati Children's, we follow children with their first episode of acute pancreatitis and enroll them prospectively into their index admission and collect data variables and demographics and follow them over time. And today I'm sharing with you the 12-month period follow-up. We collect DNA for gene testing, and in this case, we tested for pancreatitis risk genes, and then we ran the blood tests through different methodologies by clinical care to screen for diabetes, because we did have a standard of care to screen for diabetes post-acute pancreatitis at our institution. We had 120 patients and 6 needed to be excluded because 2 of them had diabetes at baseline and all the others that remained did not have diabetes at baseline. 3 underwent a total pancreatectomy islet autotransplant during that first year, and 1 had a death. The definitions were acute pancreatitis definitions as accepted by INSPIRE and NASPGHAN criteria. Severe acute pancreatitis was defined by the acceptable NASPGHAN criteria. And for the pre-diabetes and diabetes, we used the cutoff as identified by American Diabetes Association for either hemoglobin A1C or glucose values. The pancreas gene panel testing is a gene test that we have, and it obtains 10 genes known to carry risk for pancreatitis. I show here the coverage areas in the diagram. And basically, the gene test is a DNA sequencing method that enriches the exons, the flanking regions, and known intronic regions. But also, if there is a pathogenic or prior reported region that is not covered, it gets incorporated in the test. The library construction was performed using the SureSelect platform, and the sequencing was performed by the Illumina NextSeq 500 system, and the variants were classified according to the American College of Medical Genetics criteria, and only pathogenic, likely pathogenic, variants of unknown clinical significance, and risk alleles were included in the analysis. Going on to our results, we had 114 patients, so 19 were grouped as pre-diabetes or diabetes at the 12-month follow-up, and 95 had normal glycemia. And within the 19, which is the 17%, with endocrine insufficiency, 4 were diabetics at that time, and 14 were in the pre-diabetes range. The moderately severe or severe pancreatitis prior to the testing by univariable analysis was more associated with the pre-DM and DM group. In terms of genetic variants, and this is a busy table, but I do want to cover with you the most significant findings in the pre-DM and DM group. First, the CFTR5T allele was more commonly found in the pre-DM and DM group. Having any gene panel variant being positive was more common in the group that had pre-DM or DM. And the Shwachman-Diamond gene, while it was only 2 in the pre-DM and DM, it was 0 in the group that did not have DM. And then looking at the frequency of the variants detected, this is a busy pie chart, but because when you have big data, there is so many things you can do with it, I wanted to show you the frequency by A panel of the variants in each gene. And as you can imagine, the CFTR had the most frequently detected variants. All the genes were involved, though, besides Claudin-2. And then in terms of the frequency of variants in the subjects, there was 37% who had 1 variant affected, and 9% with 2, 4% with 3, and there was 1% of 4 variants and 1% with 5 variants affected within 1 subject. So in summary, we had 52% of all the cohort positive for at least of one of the variants. This oncoprint shows that I will point your attention to the bottom. There is the sex orientation, male and female, and then the purple boxes is really the ones on the far left of the ones that were excluded, baseline diabetes or diseased or a TPIT. And then the black is diabetic, pre-DM is the charcoal, and then the faint gray is the normal. And this really showed that variants in the 10 gene panel were more positively correlated in the endocrine insufficient group. Then we went on to build a logistic regression model utilizing the univariables from the genetic variants that had a p-value of less than 0.15, and those included Shwachman-Diamond gene, UBR1, and CTRC gene, as well as the 5T allele area that I showed you. We also then computed a genetic risk score utilizing this. 0 was none affected, 1 was a positive variant in any of the 4, and 2 was when you have one of the 3 genes with the 5T allele. We also did the same thing with all the clinical variables that had a p-value of less than 0.15 using a stepwise selection. And we tested the model with each time we added a variable for the improvement by the AIC criteria. And this Venn diagram on your left shows the co-occurrence of having any of the genetic risk score genes or severe acute pancreatitis in our model. And basically, we went on and developed a logistic regression-based forest plot to really indicate that severe AP had an odds ratio of 5 times more to developing pre-DM and DM, and the gene score overall was 4.88. So in conclusion, pancreatic endocrine insufficiency inclusive of pre-DM and DM were found in 17% in our cohort of children who were not diabetic at time of initial enrollment and 12 months after AP developed this condition. Pre-DM in our cohort was 13%, and if you look at population studies, it's only about 8.8%. The prevalence of diabetes in our cohort was calculated at 3.5%, which is 19 times higher compared to the general population that is calculated in children, 1.8 per 1,000. And pancreatitis risk gene, their burden and the acute pancreatitis disease severity did predict development of diabetes post-AP. But of course, we need future multi-center studies to examine this risk and actually follow children beyond the 1 year. The strengths are the observational nature design, the standardized timeline for follow-up, and pairing genetic testing with clinical data. And the main limitation is that it's a single center study, limited sample size, but for children with a first episode, this is one of the higher sample size than what we've seen before. Another limitation is that we did not examine diabetes risk genes, but this effort is ongoing already. So if you were in the prior session, I did invite you all to Pancreas Fest. If you are here, I'm inviting you for the first time. And actually, before the Pancreas Fest, July 24, there's an NIDDK pre-meeting all happening at the Westin in Cincinnati. Please look up the website for both, and registration for both is separate, but I highly encourage you to attend. There'll be lots of exciting things. And by that, I thank my team. Thank you all for listening, the mentors that helped me, and of course, the funding agencies. Thank you.
So this presentation is now open for questions. Well, Maizam, let me start by asking you, I got the impression from looking at your data that severity and the presence of multiple risk factors had about an equal, how shall I say, an equal influence on the development of diabetes. And it made me wonder how many patients, maybe there were very few, who did not have severe disease and did not have one or more of these genetic risk factors. Did any of those children go on to develop diabetes?
I knew you were going to ask this.
You did?
I didn't.
How did
no,
you know
but
that?
This is it. This is because of the lack of time, I did not show it, but this is an excellent question. So through the risk model building, you could have 6 different combinations, right? Your patient could have a mild and have a genetic risk score of 0. And that is the lowest predicted probability of having pre-DM and DM, but yet it still was observed, right? And then if you have a mild, so no severe, and then you have 1 genetic risk score, then you show the probability. So really it was highest if we had severity, but the genes are the drivers of the model.
Thank you. Dr. Forsmar.
That was great. Thank you. I was wondering, in adults, if you follow them after an episode of acute pancreatitis, they can develop prediabetes and diabetes. And it extends out for like 5 years. You're sort of accumulating new patients that have developed diabetes. What is your sense of, in kids, what happens in year 2 and 3 and 4 and 5?
Chris, this is an excellent question. My sense and my hypothesis is that we will have an increased risk over time of these children having diabetes. This K award funding has ended, so hopefully with more funding we could really follow these children over time, because there is a strong signal here. But the numbers are very comparable to adult AP diabetes episode at 1 year. So if you extrapolate this, maybe there'll be the same or more, because we have also more risk for type 1 diabetes in children, and the islet autoimmunity is very enriched in them.
That's a great talk, actually. You have done the genetic markers in all the patients. Like, I come from India. where these genetic testing is not very frequently available. But acute pancreatitis episode does predispose us to diabetes. So what is your sense on that? Without testing for, can we conduct a research on the basis of a patient having an episode of acute pancreatitis? We follow them up with other biochemical parameters to look for chances of prediabetes, diabetes, and exocrine insufficiency.
Yeah, thank you for the question. So two questions, right? Should we screen patients for post-acute pancreatitis diabetes by normal clinical testing, fasting glucose, hemoglobin, A1C? I would say absolutely yes, and should not be reserved for the ones that have necrosis or certain risk factors like autoimmune pancreatitis, because in our study and other studies, even if you lack these risk factors, you could have a risk for diabetes. The other question, genetics and single episode, it's really purely research. By guidelines, we would only do genetics for a first episode if there's a family history involved. But from a research standpoint, this is eye-opening and hopefully could give us ideas on the mechanistics on that.
Very interesting presentation, thank you. I do have a question. You had indicated about 52% of the population was positive for at least one or more variant, and also that the CFTR5T allele was the most prevalent. Did you do any analysis of the risk factor for those who had a non-CFTR variant without combination with the CFTR variant?
Non-CFTR variant, so meaning having another one of the 9 genes but not CFTR? Yes, yeah, this was done initially at the univariable analysis stage where we looked at all genes one by one through both groups, and then when we developed the regression modeling, they were tested in combination.
Okay, thank you.
Thank you.
Thank you.
All right. To close out the session here, I'd like to welcome Dr. Mitchell Ramsey. He will be presenting Pancreolipase Improves Exocrine Pancreatic Insufficiency Symptoms and Health-Related Quality of Life in Patients with Chronic Pancreatitis, Results of the CIS-CP Study.
All right, I'm acutely aware that I'm the last thing standing between you and happy hour, so hope to go through this expediently. On behalf of my colleagues, I would like to share the interim results of the CIS-CP study. These are my disclosures and the disclosures of my colleagues. As we all know, pancreas enzyme replacement therapy is the mainstay of treatment for EPI in chronic pancreatitis and is used to mitigate maldigestion, malnutrition, and other adverse health outcomes. However, there's limited understanding of the impact of pancreolipase and other pancreatic enzymes on specific clinical symptoms and health-related quality of life in real-world patients with EPI. Validated patient-reported outcome assessments are needed, especially in US patients. So here we're going to be talking about the interim results of our ongoing prospective, observational, multi-center, real-world cohort study investigating the impact of pancreolipase on EPI in patients with chronic pancreatitis. And we're calling this the CIS-CP study. So our objectives specifically were to look at the effect of pancreolipase on EPI symptoms, health-related quality of life, and stool frequency consistency. 2 of those were measured on the the PEIQ. This is a survey, and I'll show you some of those examples later on in the talk. In this study, we also looked at comorbidities, nutritional status, safety outcomes, and you'll hear more about that as the study's finalized. The last thing to note at this stage, the study was sponsored by AbbVie, and so we used a AbbVie manufactured drug Creon, specifically the 36,000 unit tablet, and that's, when you hear the doses, that's going to be the specific formulation. So I'll walk you through the enrollment criteria. We included adults with probable or definite chronic pancreatitis and EPI, which was defined as a fecal elastase less than 200 micrograms per gram of stool, as well as a clinical diagnosis of EPI. Subjects had to have at least moderate severity of EPI symptoms as defined by a PEIQ symptom score greater than or equal to 1.4. Subjects were initiated by the treating clinician on pancrelipase, 72,000 units of lipase per meal, 36,000 units of lipase per snack. This was not provided by the study, it was observational. Finally, we included those who had never or undertreated EPI. We defined this specifically as no PERT within the last 3 months, or if they had been on PERT at a low dose, they were allowed to enroll as long as they didn't have any PERT within the 7 days prior to enrollment. We excluded subjects with a number of comorbidities that you can see listed here, specifically cystic fibrosis, pancreatic cancer, clinicians' strong suspicion for small intestinal bacterial overgrowth, and bowel surgeries. Also, we excluded those who had received antibiotic therapies within 10 days or concluded less than 7 days prior to enrollment, and we did not enroll those who had planned pancreatic endotherapy or surgery coming up during the study period. So this is our study design. The initial visit, the screening or baseline visit, allowed us to confirm the CP diagnosis, confirm the diagnosis of EPI, and clinicians would have started patients on pancrelipase, either 72,000 with meals, 36,000 with snacks. At that time, patients were invited to complete informed consent as well as the PEIQ survey. Those who had a PEIQ symptom score less than 1.4 were ineligible for participation, but those who had a symptom score greater than or equal to 1.4, which indicates moderate to severe EPI symptoms, they were eligible. Subsequently, the site would complete vital signs, nutritional markers, hand grip strength, as well as the PEI. They'd already completed the PEIQ, but they'd also complete a PROMIS, as well as a stool frequency and consistency score. Approximately 1 month, plus or minus 2 weeks later, subjects would return for a repeat visit, at which time we would go over dosing and administration, ensure they were taking at least with some consistency. Also, we would go through a diet questionnaire, primarily looking to ensure that there had been no major changes in the diet from enrollment. Also, there was a dose adjustment questionnaire when it was needed. If patients had been taking pancrelipase consistently over the last 7 days, then they would also complete a PEIQ, PROMIS, stool frequency and consistency. One of the benefits of the design is if they said, oh, I was out of town, I missed a bunch of days, we could just bring them back in a week when they'd had some more consistency, as long as it was in that 1 month plus or minus 2 week interval. The last study follow-up was at 3 months plus or minus a month, where a lot of these same outcome measures were obtained. In addition, we checked a weight, blood draw, hand grip strength. And as I mentioned, today's presentation, we're going to go through the results of some of these surveys. I've mentioned it a couple times, but this is the Pancreatic Exocrine Insufficiency Questionnaire sort of summary. This is a validated patient-reported outcome tool for measuring the severity of EPI for patients with cystic fibrosis or chronic pancreatitis, and it consists of 3 different sections. The first one looks at abdominal symptoms, and this includes 7 questions graded on a 5-point scale from 0, not at all, up to 4, quite a lot. And this includes things like bloating, for example, or postprandial abdominal discomfort. The next section is bowel symptoms. This is 6 questions, again on the same grading scale, and this includes things like steatorrhea, urgency. Those 2 symptoms are added together and they create the symptom score, the SS. And then the last group of the survey is the PEIQ impact domain. And this looks at impact on daily life. For example, how often do you avoid going out with friends because you're worried about your EPI symptoms? And that's the impact score, the IS. And these can all be averaged together for the TSS, which is the total summary score. But primarily we look at them separately because they really measure distinct aspects of the EPI disease experience. As I mentioned, we had a number of endpoints, and today we're going to be talking about these ones in the darker color, and the grays will be in the final report coming out in the future. So I'll walk you through briefly through this table of results. We had 26 patients who were analyzed at 1 month and 21 who completed 3 months of follow-up. Of the 26 who had 1 month follow-up, this is sort of their summary statistics. We had a mean age around 59, median weight of 160 pounds, and you can see that that was pretty evenly distributed in different BMI categories. We had probably the most of them were in the normal to overweight groups, and then a few less in the underweight and obese groups. Some smokers, some alcohol users, half with diabetes, 62% initially presenting with steatorrhea, and we had generally very low fecal elastase scores. So again, this is very, I think, similar to what you might experience in your adult pancreas clinic as well. This is the symptom score at 1 month, and on the left you can see the mean change from baseline, which was our primary endpoint. At baseline, the score was 2.4, and after 1 month of treatment with pancreolipase, that had gone down a significant amount by about 1 point. On the right, you can see that same data presented a slightly different way. This is the percentage of patients who had at baseline either severe or moderate symptoms. And then after 1 month, you can see that there's a much lower proportion of those with severe symptoms and a much higher proportion of those with mild or no symptoms. This is the follow-up data then at 3 months, and you can see a very similar change from baseline in the mean PEIQ symptom score by about 1 point. And then if you look at the right, you had, again, a difference in the distribution of symptom severity at 3 months. One thing that I found notable was that at 1 month, about 7% of patients had no symptoms. And then here at 3 months, that number's a little bit better. And so here we see 19%. Lastly, health-related quality of life. We found a significant improvement in this at both 1 month and 3 months. The health-related quality of life impact score, the PEIQ impact score, doesn't have a mild, moderate, severe. It's more just a gestalt of the impact. And so this doesn't have a severity attached to it, but it also improved at 1 and 3 months. Lastly, stool consistency, to my eye, looks maybe a little bit different in the patients who are describing abnormal versus normal, but it was not a overwhelming difference and really was not significantly different at 1 month. In conclusion, we demonstrate for the first time significant and clinically meaningful improvements in EPI symptoms and health-related quality of life using the validated PEIQ in a real-world population of CP patients with EPI when treated with pancreolipase. Again, that was at the 72,000 dose with meals, 36,000 with snacks. The improvements in EPI symptoms and health-related quality of life were sustained through the 3-month observation period, and I think for the symptoms, they may have even improved at the 3-month period. Lastly, the PEIQ may represent a useful tool in the clinical management of EPI in patients with CP and warrants further study and warrants, I think, inclusion and a lot of other EPI symptoms moving forward. I'd like to thank all the subjects, the site research staff, and investigators. You can see it was a multi-institutional effort in order to recruit and complete this study. So with that, thank you, and I'd be happy to take any questions.
Right. Any questions on this final abstract?
So, Mitch, I have a question. More than half of these subjects were diabetic. And we have to ask the question, did the presence of diabetes affect the outcome of the treatment with the pancreatic? In other words, was it a non-factor, or in fact, was it responsible for failure to improve with enzyme replacement?
You know, that's an interesting question. Does diabetes affect your response to pancreas enzyme therapy? We did not look at that specifically. We know the two are closely linked. In my mind, I tend to think that EPI control has a greater effect on diabetes control rather than the other way around. But certainly, very high blood glucoses, very low blood glucoses, those are going to change GI motility. So it may be a bidirectional effect. We have not looked at that in the data to date.
Okay. Dr. Uch.
I can ask a question. So that's great. So a lot of times patients don't understand how to take the pancreatic enzymes, or they're not compliant, or there are a lot of understanding or misunderstanding. There's a lot of research, especially in the adult GI world. So how much do you think your data that is so compelling have contributed to this, that, you know, the patients are understanding they're compliant. I mean, you have seen them and confirmed that they were taking the enzymes, at least at the time that you collected the data, and that you had a good communication with the patient. So how much do you think that contributed to your positive results?
That's a good question. I mean, certainly we enlisted and recruited those who were interested in longitudinal follow-up and who were bought in enough to go through the paperwork. Now, I will say that this was a real-world study. I mean, we didn't have blister packs to really call patients every day, remind them, did you take your enzymes? Did you take your enzymes? So it was not as rigorous in terms of ensuring compliance. Now, when they did come in for their follow-ups, we defined regular use of pancreas enzymes as long as they were taking, I think it was like 140,000 units throughout the day. We considered that use. I think one of the challenges is, as you mentioned, there's a huge pill burden. It's frequent use. And patients don't eat the same number of meals or snacks or grams of fat from day to day. So when you look at the compliance, it's very hard to enforce it sort of on our end. It's more so providing that education and then having to, I guess, have some trust that they're using it as they say they're using it, as they feel is appropriate. I will say that the timing of the scheduled visits, I think, is a useful paradigm for reinforcing education to patients. In this study, the 1 and 3 month visits were really completed by like the research coordinator. And so there wasn't a physician seeing them at 1 month saying, do you still have symptoms? Do we need to change your dose? Those kinds of things. But I do think in clinical practice that 1 and 3 months after prescribing enzymes is a very useful interval to remind patients, how are you taking it? How many grams of fat? So on and so forth.
Thank you.
Thanks.
That was a great talk. Congratulations. My question is kind of a follow-up on Dr. which is number one, I wondered if, actually I have 2 questions. What do you think about the placebo effect of administering pancreatic enzyme capsules in this population? I know it's a real-world study, and so you probably can't answer that from your data. That was the first thing. And then second, I just wondered if you do have food frequency data, for a dietary questionnaire or any other information about changes they may have made during their participation in the study.
Yep, both great questions. The first one, you're right, because it was a open label, real world, we did not have a placebo control arm, so there certainly could be some placebo effect in reporting their symptoms or their health-related quality of life. To answer your second question, we did not include a formal food frequency questionnaire. It was really just, have you changed your diet at 1 or 3 months? And the majority of folks had not, and that's why we continued to enroll them. So unfortunately, don't have that information.
All right. Thank you very much, and thanks to all of the presenters in the audience today. We'll close the session.